Hi, Dr. Centeno. I got a little cold today, so you may hear me cough a little bit. So just kind of warning everybody. Hey, I think I'm just going to do an Ask Me Anything. I'm still down in Grand Cayman. I come down here twice a year to use this licensed facility where we can do culture expanded cells. Don't really treat CCI down here, but treat lots of other things. So I wanted to make sure I got some questions answered because I know I wasn't on at all last week. I was down here. So I'm going to primarily try to answer questions that have been submitted, but obviously I'll be online here for the next half hour or so. And if somebody wants to jump in and ask some additional questions, feel free to do so. So let's start with Alicia Mann. If someone needs multiple treatments, is there typically any relief of symptoms in between? What does pain management or rehabilitation efforts typically look like after procedures? So yeah, Alicia, I would say the most common thing would be to get interval improvement from each treatment. Now, we do have some patients that don't get any relief from the first. We'll usually repeat the DMX to make sure we're on the right track. And then they might not get relief till the second. And then pain management after procedures really depends on what the flare-up is like, and that's very, very different for each person. So obviously we would use medications for pain management, and rehabilitation generally doesn't start until after you get approved by your doctor to do that. Michelle Kusher, are there situations where bone marrow concentrate could permanently weaken ligaments? I'm thinking of the various phases and if the progress to strengthen ligaments can go awry. Not that we've seen to date, Michelle. I guess it's theoretically possible, but not that we've seen to date. Alicia, for those who live out of state, how much consultation is allowed over telemed versus how much necessitates in-person visits? Alicia, we always try to do a telemed first to make sure that someone is a good candidate for what we do and to go over as much information as we can. But there's certainly things we can't do via a telemed, meaning I can't, excuse me, perform a hands-on physical exam, that kind of stuff. So there are limitations to that. And then Alicia, for initial and following procedure, what does follow-up care with the clinic look like? Follow-up care is mostly going to be coming in after the procedure if you're having any issues while you're still in town, and or working with Carla to try to figure out whether or not the procedure was successful. We also might recommend additional types of care, etc. Fat John, are lax ligaments inflamed, meaning is there active inflammation then before any injection treatment? Yeah, Fat John, I think the problem would be for lax ligaments is they're generally chronically inflamed, and that's different from acute inflammation. Acute inflammation can help with healing, which is what we try to kick off in these injections. But chronic inflammation can just cause more damage to the ligament. So two very different concepts there. Sharon, I have an idea for the videos, how CCI can affect the rest of the body for those with hip degeneration, etc. Yeah, that's a good one. For instance, we know that people with chronic neck problems can lose the ability excuse me, to actively stabilize their lumbar spine. So that's certainly an important one. Bethany, hi, Dr. Centeno. I don't have excessive overhang on my DMX, although you said may show damage to my alar and transverse ligaments, as well as swollen facet joints. Having said that, my DMX shows my spinous axis rotation of C2 rotates 12.5 degrees to my left and rotates 10.5 to my right. Could this be irritating the cervical plexus? Yeah, I mean, certainly when you have C1, C2 instability, you can get rotation. I've blogged on that before. So that rotation can cause lots of different things to be irritated, everything from swelling in the joints that we discussed to irritating cervical plexuses, etc. Let's see here. I think it's the same person. Hi, Bethany again. Hi, Dr. Centeno. I watched your video on the study you did of the 30% of patients who didn't see symptom improvement on their first picl. After looking at the post-DMX, I actually found there was structural improvement. Having said that, it seemed like the ones that didn't have any symptom improvement or structural improvement had already started off with minimal overhang. It does indicate that if we start off with minimal overhang, that we might not get improvement from PICLs. Not necessarily, but if you're starting with minimal evidence of instability on movement-based images, not just overhang, we look at other things too, then it's going to be hard to track that patient for improvement, because what we track when there's no subjective improvement is objective decrease in motion of the unstable part. So if there's not a lot of objective decrease or increase in motion to begin with, hard to track that. And then Bethany does a slightly tilted head indicate issues with the facet joints or alar ligaments. Can a tilted head be fixed? Yeah, that generally means that either there's a scoliosis or a side bend in the lower spine, or that can happen as well because of bad proprioceptive input from the upper neck. Stacy Kaufman, thanks for including me. Or, Dr. Centeno requires a minimum of DMX, but if he could have everything he wanted, whether diagnostics would he like for most complete picture, MRI upright, MRI rotational CT. Yeah, Stacy, the two things I need are some sort of cervical MRI and then a DMX. Now, is it great, for instance, to have one of Dr. Rosa's super duper upright MRIs? It's always great to get that additional insight. So that's something I might recommend, but it's not necessary for all people, obviously, to get to a diagnosis of craniocervical instability. Diana, I'd actually know how long before PRP up for sets and neck do I have to avoid NSAIDs? Anything else to avoid? Yeah, so I would say at least a couple weeks before. What's the difference between basilar invagination and cranial settling? How do these impact PICL or PRP outcomes? Do injections help? So basilar invagination is when the dens is putting some pressure on the spinal cord. As far as cranial settling, that is the concept is the head is falling lower. Again, those are static concepts. So instability is a dynamic thing, meaning it's a movement-based process. So we tend not to like to use static measurements like a CXA because it has no meaning in the context of instability, right? Instability means that I move around and something's moving too much that shouldn't move that much. But a CXA is a static measurement, as are these other things we're talking about, basilar invagination, cranial settling, etc. They're based on the old surgical idea that what I call the angle, the dangle, and the squiggle, the wiggle, meaning we don't have high-level evidence that these kinds of things, for instance, a low CXA, helps to differentiate normal people from those with this problem, meaning there's lots of people out there walking around with low CXAs who have no problems at all. So that's why we always focus on instability measurements and looking at craniocervical instability. Now, I know a lot of the surgeons love these static measurements, but to my mind, they're very, very poorly validated in the literature, meaning we don't have good research showing that these measurements can be used to randomly pick people out of a crowd in an accurate way who have this kind of problem. And that's the biggest issue with those static measurements. So we generally don't track them. Liam, how long should I fast prior to bone marrow draw for PICL? We really just recommend the night before. So just the night before. Would a no-carb keto diet boost total stem cell count? No one knows that for sure. How long before bone marrow draw should keto diet be followed? I don't know that we're recommending a keto diet, just a low carb, low sugar diet. And then Liam, I have neurologic symptoms since CCI onset, visual snow, tinnitus, head pain, or pressure. Is there any way to easy, non-invasive way to tell if these symptoms are from the brainstem compression? There isn't. And that's the problem, Liam, with this entire field of claiming that people have these issues due to high intracranial pressure, because there's no test I can run or anyone can run to confirm that concept. The only thing we can really do is to do something that's supposed to fix that and see if those things go away. And that's the difficulty I always bring up with those sorts of symptoms and this idea of high intracranial pressure. Do we have CCI patients with high intracranial pressure? Yes. Is it sometimes causing symptoms? Yes. Treatment's still the same, which is to reduce the instability. And there isn't a test I can run that can confirm that this idea of high intracranial pressure is causing those symptoms. And that's a problem. That's a real problem with that diagnosis. Some more questions here. I just got sent. I think I have that. Fatchin, I can't tolerate a cervical pillow, which in theory should help the curve. Is it because the curve has already been lost and trying to restore it without addressing the instability creates pain? Usually, that's a good explanation, Fatchin. Fatchin, should it be easier for a prolotherapist under ultrasound guidance to at least inject the posterior longitudinal ligament or SSIS process with PRP or Prolo and lower cervical below C2? Well, you can't get to the posterior longitudinal ligament that way. You could get to the supraspinous, interspinous ligaments that way. And I think if it's done safely by someone who understands how to do that injection and can be done very competently under ultrasound. The problem is when we see clinics trying to inject above that with ultrasound, or even clinics trying to inject above that with x-ray guidance that don't have the training and experience to do it. There was just a huge, serious complication that happened here in the U.S. from a doctor attempting a high upper cervical facet injection. And it just, shows you that, that's something that's rarefied air. So that patient shouldn't believe that they can walk into any clinic and get that procedure done. Fatchin, some prolotherapists argue convinced of the idea that not just the junction, but the entire cervical is to be injected. This is because there are hidden areas of instability and muscle self-protects during scans. Yeah, so Fatchin, I think what you're thinking of there is absolutely, if you've got an upper cervical problem, you should inject all the cervical ligaments. The problem is that those prolotherapists don't have the ability to inject the upper cervical spine safely. So injecting the entire cervical spine ligaments, so supraspinous, interspinous ligaments all the way down, is something we always do. It's just less effective, obviously, when that's all you can do and the problem is really higher up, or the main problem is really higher up. So yes, if you're injecting the hypercervical spine, you should inject all those cervical ligaments, and that's what we do. Having said that, if you've got a hypercervical spine problem, then injecting the lower cervical spine ligaments isn't going to help all that much. Fatchin, why do some doctors use posterior PRP plus Pro at the same time in the cervical spine? Because they're idiots. There's no other way to answer that one. You can't use prolotherapy with PRP at the same time. That creates platelet raisins. And what I mean by that is that prolo is hypertonic. So it pulls water out of the platelets, dehydrating the platelets and making them less functional. So you definitely don't want to mix those two together. So if a doctor is mixing those two together, they regrettably didn't make it past basic chemistry, or at least they forgot basic chemistry, because that's what happens. And then does increasing the targeted area decrease the benefits of injecting only a specific portion? I'm not quite sure what you mean there. Certainly, the concept should be specific and global, not just specific. So if you're injecting C1, C2, you're also injecting all those other cervical ligaments as well, for example. And then I don't know if we have any live questions. Look like we do here. I'll try to get to many of those as I can. Mike, Eagle syndrome. What about the calcified ligament is causing internal jugular vein stenosis as shown on CTV? Yeah, Mike. So the reason that would happen in a CCI patient would be that there's instability, and you want to get rid of the instability first because that's the least invasive thing that you can do. Now, is it possible that if you can't get rid of it that way, you'd want to cut that ligament? That's certainly a possibility, but cutting the ligament is more invasive than getting rid of the instability from an injection standpoint. So you never do something more invasive or start there. You always start with the least invasive and move up the ladder of invasiveness. So this idea that you want to go ahead and cut the ligament first is not smart, not only because it's more invasive than doing injections, i.e. to provide stability, but also because you're destabilizing the anterior neck stability system, because that ligament is involved in that system. So you can't, it's not a very elegant way to treat someone who has craniocervical instability by causing more instability, right? That's not good. How to beat benign fasciculation syndrome. I don't know if there is such a thing as benign fasciculation syndrome. Outside of that, sounds like a made up thing that some doctor threw a label onto. If a muscle is fasciculating, there's a reason the muscle is fasciculating. That means the nerve supply to the muscle is not healthy. Now, there certainly may be congenital problems where someone just has fasciculations without any nerve irritation, but in an otherwise normal system, that's an indication to look at the innervation of that area. Screw the world. Slap tear with posterior extension. PRP seems discouraging. Any way to avoid surgery for a slap tear? Physical therapy has not allowed working out again. We treat that commonly all day, every day. Not a problem. High rates of success. It's usually an instability problem where the shoulder capsular ligaments are lax. So they've got to be tightened down through very precise injection. Not hard to treat. So I'm not quite sure why it would be discouraging. Levon, hi, Dr. C. When it comes to disc bulges, are you okay with spine MRI, which is a little older than 1 year? Do you require a fresh spine MRI? Levon, a lot of that depends on whether or not there's been a substantial change in condition since that time. If there's been no change in condition at all, then we're probably fine with an MRI that's a little bit more than a year old. But obviously, if there's been a change in condition, we'd want to see another picture. Deanna, hi, Dr. C. Can tight trap muscles cause impingement of blood flow or CSF flow when you sleep? If the muscles are guarding due to instability, what else can be done to decent sleep while you wait for recovery from PICL? Tight trap muscles shouldn't cause impingement of blood flow in the spine or CSF. And if the muscles are guarding due to instability, you might consider things like sleeping in a cervical collar to try to provide just better instability only at night when you're laying down. Christopher, let's say that you have a vertebra that has too much range of motion due to capsular ligament being overstretched from a chiropractic adjustment. Can the ligament be tightened and shortened? In general, yes. We are live right now. Yes. Deanna, can tight trap muscles cause impingement of blood flow? I got that already. And Megan, how can you fix disruption to muscles of skull with Saunders unit traction machine? I wouldn't think you could fix disruption of muscles of the skull with a Saunders unit traction machine. So I don't know how to answer that one. I don't think that's possible to do if there's an actual disruption of the muscles of the skull. Okay, guys, so I wanted to just get some questions answered while I'm down here in Grand Cayman, and happy to take a few more questions. I've got about 5 more minutes before I've got to see some patients here, but I did want to just try to quickly get some of this in today. Yeah, Megan, I think you may want to see someone who has some expertise in all of that stuff. Doesn't sound like your life is ruined, but certainly expertise makes a difference in those sorts of problems. Okay, guys, well, I think I answered the main questions. I'll try to do one more of these maybe sometime this week before I start heading back to Colorado. Just try to stay on top of questions and make sure that people have an outlet to get their questions answered. I know I didn't really advertise this time, and I had talked about doing a specific lecture, but a smaller format of time than I expected. So I wanted to just jump on here, and if someone had some questions, I could answer them. And then obviously we took some questions that people had posted previously. So you guys have a great week. I'll try to do this one more time sometime this week so that I can make sure that everyone has an outlet to get their questions answered. Apologize for not doing this last week, but I was down here seeing patients, and it's always a little bit tough when I first get down here, just trying to get caught up and back into the swing of things. So thanks so much for watching today. I know this was a quick one. And Daniel, can CCI cause really high blood pressure and high ocular pressure? CCI can certainly, well, taking certain drugs can cause high blood pressure. Being less active, it can cause high blood pressure. CCI associated with those things. High ocular pressure. Can CCI cause high ocular pressure? We don't really know that one for sure at this point, i.e. in the type of CCI we're talking about. So I've actually seen providers try to do this to measure ocular pressure. I wouldn't pay for that test right now if I had CCI. I'm not quite sure there's much information we're gaining there. Screw the world. Not loving that handle there. Kind of nihilistic, but not seeing any studies demonstrating PRP actually healing a shoulder labral tear, pre and post MRI demonstration proof of healing. We do it every day. There's studies on PRP. I don't know, 40 or 50 randomized controlled trials right now. Hey guys, I'm going to run because I got to start getting back in to see my 1 o'clock patient here, which is a complex procedure. So have a great week, and I'll try to get back to you sometime later this week. Thank you.